Thank you. Well, I don't care. The thing is that we've been observing a swing in evidence in critical care medicine. So we regard something as a life-saving intervention, and in 1 year we regard this as a deadly intervention. And this causes a swing. And one of my good friends said that the only remedy against evidence-based motion sickness is to stick to the pathophysiological principles. So this is how I'm going to build up my presentation. It's, regarding physiology, there are no secrets. We have to breathe. We breathe spontaneously, roughly 15 times per minute. We breathe on a 3 to 4 milliliters per kilo tidal volume. The pressure changes within the lungs with just a few centimeters of water, and we breathe 21% oxygen. And with this, we achieve a PaO2 something like 100 milliliters of mercury and a PCO2 40. So, well, you all know that, but has any of you asked the question, why is it so? Why do we have to breathe 21% oxygen? Why is PaO2, PCO2 like that? And the answer is very simple, but just as important, because it's good for us. So if it is good for us, anything what is not physiological is no good for us. So this is going to be my, my track I would like to follow you on. So hypoxemia, normally, and I agree totally with Carlos, that it's not only in the operating room, but you in this room, your alveoli are all open. And the gas exchange takes place continuously. So the venous blood comes from the right ventricle within a fraction of a second, fully saturated with oxygen, and leaves the alveolus as an oxygenated blood. On the contrary, if there is no air, no oxygen in an alveolus, then the venous blood comes here in vein, doesn't get oxygenated, and leaves it unchanged. This is termed shunt. And in our hypoxemic patients, there is a mixture of the two, which is called venous admixture, meaning that our patients have normal open alveoli, and they have a substantial amount of closed alveoli, whether it's atelectasis, sputum, whatever, it doesn't matter. But the end result will be that there is a drop in arterial oxygen content. To treat that, the simple thing to do is to give oxygen. By doing this, you increase the alveolar partial pressure of oxygen. And also there is a physiological process that helps our patients, because there is a hypoxemic vasoconstriction which shifts blood from the non-ventilated alveoli to the well-ventilated alveoli. And these two mechanisms will result in an improvement in oxygenation and oxygen content. Obviously, the higher the FiO2 that is required to maintain adequate oxygenation, the greater the shunt, as is nicely demonstrated by Professor Nunn's iso-shunt diagram. Now, if the shunt, the venous admixture, is equal or higher than 50%, that flat line indicates that you cannot improve the situation just by increasing the inhaled oxygen concentration. So what we have to do is to recruit non-aerated lung areas back into respiration. There is no way out. For that purpose, we apply positive pressures, and there is a very important therapeutic dilemma here. In medicine, any injured or inflamed organ is put at rest. And what we do with this injured, inflamed lung, which is accustomed to low pressures and low FiO2, we bang it with air, so with positive pressures, high oxygen concentration. So it can do harm, no doubt. And on the other hand, IPPV, mechanical ventilation, is a life-saving process. Don't have any doubts that this is so. In fact, it was indeed life-saving in 1952 in Copenhagen during the polio epidemic, when Björn Ibsen, the anesthesiologist, started to intubate those patients. And by doing this, the mortality that was almost 90% in July dropped down by 60%. Not many medical interventions can produce such an improvement in outcome. And interestingly, the paper was published in Lancet, and there is only one author, Dr. Lassen. So you know, I am an anesthesiologist, it's the same old story. We do the work and physicians take the credit. So nothing has changed over the last 60 years in history. So, however, we do have evidence that if we apply mechanical ventilation inappropriately, then it can be deadly. This is a lovely video, I don't know how well you can see it, This is a healthy rat lung during ventilation. And you can see the acini and the alveoli, and they increase in size and they shrink in size according to the respiratory cycle. However, when the animals developed ARDS, there's a completely different picture. At the end of inspiration, the lung becomes a bit aerated, but then as the pressure and volume decreases, there is atelectasis occurring again. And this closing and opening can cause serious damage. So when we inappropriately ventilate our patients, there are two potential harms. One is atelectotrauma, this opening, closing, and the other one is overdistension. And there is a large amount of evidence that it produces inflammation, and these inflammatory markers can invade circulation, and then they can cause organ dysfunction in distant organs and eventually death. So the rational and recruitment, the way I see it, because I just entered the room, so I don't know what the previous speakers said about it. So this is kind of my philosophy behind lung recruitment, and I use, to demonstrate it, this series of CT scans published by Gattignoni and Pelosi, well, back in the 2001. So this is a pig lung CT. You can see that there is a ZEEP pressure, zero airway pressure. There is hardly any aerated lung. And when you increase airway pressure, more and more part of the lung becomes aerated, and at very high pressures, the whole lung was eventually aerated. This is a sigmoid-shaped curve, and there are two inflection points. So it follows some kind of logic that if you set your PEEP somewhere here, and you set your peak inspiratory pressure somewhere here, and you ventilate patients, animals, whatever, between those two pressure points, then you can prevent progressive atelectasis here, and you can prevent overdistension over there. By and large, this can be summarized as the open lung concept, and there is also another important part, is lung protective ventilation, limiting tidal volume close to the physiological. Now, I have a problem with this 6 milliliter per kilo. I have a problem because I'm a head of department, and many of my physicians love evidence-based medicine, and the only thing they look at is whether the tidal volume is 6 milliliter per kilo. Now, let me take you to a journey with this. I borrowed these pictures from Marcelo Amato with his permission. If you deliver the magic 6 milliliter per kilo tidal volume into a lung, which is open, like any of you in this room, then the transpulmonary pressure will be low and you do no harm. However, if the lung is atelectatic and you pump the same amount of air into a very tiny area of the lung, you will cause a serious increase in transpulmonary pressure, and you can cause serious barotrauma. However, just looking or listening to the chest, you don't know what is the degree of atelectasis in the lung. And in this paper, Amato and co-workers nicely demonstrated that it's not really the PEEP or the peak pressure that matters, it's the driving pressure. What they did was they collected all data from large ARDS studies, and 1,500 patients were resampled. And there was a group of patients in whom the PEEP remained static and the driving pressure changed. In this group of patients, the driving pressure remained static and only the PEEP was increased. And here the plateau pressure remained static and the PEEP was increased. And they looked at mortality. We're talking about a large patient cohort. And there was significant increase in risk of dying in this patient cohort in which the driving pressure was increased beyond measure. And in these patients in whom the driving pressure remained static, there was no effect on the outcome. And these patients in whom the driving pressure was reduced over time, their chance for survival increased over time. So it's not really a PEEP, not even the plateau pressure, but the driving pressure that we should really pay attention to. However, all of these studies were done in patients undergoing controlled mechanical ventilation. On my ICU, 95% of patients are ventilated in a CPAP pressure support mode, even in those with severe ARDS. Now, in patients on pressure-controlled ventilation, because if we do controlled ventilation, usually we use pressure-controlled ventilation, this is what we do. Well, this is an old paper, what we published in 2007, and the main task of this study was to see the hemodynamic effects of lung recruitment. So the study had two phases. the recruitment and the decelerating PEEP titration. We used the 40 by 40 approach. So I'm not going to tell you the details of that study, but let me just point out one thing which was out of the results. That after the recruitment maneuver, the oxygenation of these patients increased by 61%. And I think this is a major achievement. But what is the evidence? So all the physiological rationale, what I've been talking about, when we put it in the result of clinical trials, then I will only quote two very recent reviews just come out within the last couple of weeks. This one, published in Journal of Critical Care, looked at several studies, and when we look at mortality, there is a tendency of in favor of those being in the recruitment group. However, it did not reach statistical significance. And the same holds true for barotrauma, which favored the control group. However, it did not reach statistical significance either. However, the authors concluded that oxygenation has been shown to improve as an effect of lung recruitment in patients with ARDS. The other very recent review published this figure, which wasn't the product of the authors, but it was the Kessonian group, and they measured aerated lung with a CT scan. And what they found was that in patients who have severe ARDS, then lung recruitment resulted in large improvement in the aerated lung tissue. Patients with mild ARDS, it wasn't as effective. And they also recommend to use the open lung concept in patients with severe ARDS, however, only in those who are responders, who will respond to recruitment. They say that the exact definition of a responder remains to be elucidated. So let me give you my approach, how I measure whether the patient is recruitable or not. Before I tell you how I do it in practice, let me show you the results of our study that was done. It was a recruitment study in patients on CPAP pressure support mode with tracheostomy. And we performed a lung recruitment maneuver, and 73% of our patients responded. The endpoint was improvement in oxygenation. So 73% of patients responded with an improvement in oxygenation. However, the remaining 25% of patients did not respond with an improvement in oxygenation. In fact, oxygenation became significantly worse during lung recruitment maneuver. In the responder group, half of the patients responded with a less than 50% increase in PO2 PF ratio, but there were high responders whose PaO2 F ratio increased by more than 50%. So a very effective result. Now, in addition to oxygenation, the other significant finding in the non-responder group was compliance, which decreased significantly, and compliance differentiated responders from non-responders with very high efficacy. So finally, I'm going to tell you how I do it at the patient's bedside. This is one of our patients who is on 50% oxygen, CPAP pressure support mode, 10 of PEEP, and 15 pressure support. The numbers are small, so I enlarge them. So the patient is on 10 of PEEP, 15 pressure support, and with this, the tidal volume hovers around 500 milliliters. This is a blood gas. Again, the numbers are small, but the important bit is this. So the PF ratio works out as 145. So what I do in these patients, I increase the PEEP for a start. You can increase it to 12, 14, how you feel like it. It doesn't really matter at the beginning. So I increased it on this occasion to 14, and then I start increasing the pressure support by 5 centimeters of water at a time, and I look at two things. One is whether increment in pressure support causes an increase in tidal volume. This can occur from two causes. One, that you indeed recruit lung. The other one, that the patient has good lung compliance, and then you overstretch the lung. This is why I look at saturation. So if saturation goes down, then I stop. If I increase pressure support further, but tidal volume doesn't increase, I stop. So I try to avoid barotrauma. So I increase it, whatever, 30, I usually don't go higher than 30, 35 centimeters of water. And I keep increasing the pressure support till tidal volume increases. I keep an eye on the saturation. And when I am happy, I recruit it, then I reduce the pressure support back. And in this patient, there was not a big deal, but I could have produced better results, but I didn't have my camera with me in other patients. But nevertheless, there was a substantial increase in FiO2. So the next step, I can reduce a PF ratio, so I can reduce FiO2, getting closer to the physiological 21%. And this is the whole point of lung recruitment. However, sometimes it doesn't work. This is a 35-year-old woman. She developed severe ARDS after a road traffic accident. So she was on 80% oxygen, 10 PEEP, saturating around 90%. And so I did my recruitment maneuver. She responded with increase in tidal volume, but so the compliance was very good in this young lady, but as saturation started to drop. So I said, okay, there's something wrong here. This patient is not recruitable. Let's do a CT scan. And the CT scan, what you can see here, revealed massive atelectasis on the dorsal part of the lung. So what we did, we turned the patient prone, and within minutes, the high FiO2 requirement was reduced to 35%. So let me conclude with Bob Kaczmarek's recent, not that recent, editorial or review paper that, and I agree with him, he is the next speaker in the session, that it is useful improving the PO to FiO2 ratio, and it is safe in trained hands, of course. So the answer for my provocative title, that I don't care of the evidence, so I don't do recruitment maneuvers to improve outcome. I do it to get closer to physiological values, to be able to reduce the driving pressure and to reduce the FiO2 and to provide better oxygenation. Why? Because physiology is good for us. Thank you.